But it's so true because we've had these experiences where you start the surgery, the patient's pupil is probably not dilated. You're probably telling your staff outside, or drop dalo, which can cause an increase in the blood pressure. Patient comes into your OT, you start operation, the pupil shuts down, you're already under pressure to deliver, and that can cause a total disaster. So please, as a family physician, remember this point, and it will really help the surgeons and your patient, of course, and the reference to that doctor again. So it's something that you all should be aware. Transient UV-max can cause something called as floppy iris syndrome or service caries. So, something about, like we discussed, monofocal and multifocal lenses. Traditionally, most of us used to implant monofocal lenses in a cataract surgery patient, which would give them great vision for distance, and we would probably then, if you operated the other eye, give them a little better vision for near. So in effect, a patient will see for far and near with both eyes, but individually never see both. So sir will just tell us about the advances in
you see, essentially, multifocal lenses come in two basic categories. Those which have got rings, which give intermediate distance, intermediate near, 5 rings in a row, or a multiple set of rings which works in a totally different view, what we call as a diffractive multifocal, as compared to the previous one which is called as a refractive multifocal. Refractive multifocals have the advantage that they are cheaper. Diffractive ones are a little costlier, but leaving the cost aside, the diffractive ones have less visual problems. What is the trade-off which you have? The trade-off you have is that you tend to see ring-around objects at night. Frankly, it is a very overrated complaint. You sit in your car at night and you look through the windshield and you look at the street lights, you see lights around every single point, you see a reflection around every single point of light that you see. Your brain is adapted to it, and it assumes that when it sits in a car, you will see it. It doesn't worry you. You are driving equally well. Those of you who wear glasses, go near a tube light, you get a reflection of the tube light on top. It doesn't worry you, because the brain, after a certain period of time, washes it off. With the result that the same thing applied to multifocals. Yes, for the first 3 months or so, you will see rings around the objects in light. And yes, when at the pitch dark night, there is a bright spot of light, he will see part of an arc. I tell my patients who are multifocal that if you see part of an arc, be happy, because you can only see it if the lens is well centered. So you have to convert a liability into an asset, essentially. So you have patients who come and say, Dr. Saab, acha dikhta hai. He's happy about it. But leaving that aside, it does not compromise. So the main criteria why we say we should not do multifocals, we leave that aside. Multifocals, the assumption, unfortunately, which all patients have is that they see perfect distance in near, which is not true. Why? Because irrespective of how accurate the surgeon is, the maximum accuracy you can have is plus minus 0.75. It can't go better than that. You are fitting a lens into soft tissue. You are not fitting into a hard tissue where you can use a micrometer stability. So a certain amount of fall in vision is there, and the patient has to be told that your reading also doesn't mean you are going to read classified adverts. For that you will need to have a little reading class, but 80% of the time you won't have classes. If he accepts that, then multifocals are the way to go. As a matter of fact, most of my practice just now is multifocals. Interestingly enough, a child has a cataract, age of 5, 4, 3. Multifocals are the way to go. Children adapt to multifocality almost instantly. So, though what I'm saying, I say with a little caution, because not everybody agrees with what I say. Multifocal in children works great. And that's what I do as a routine in all my cases. But that's a different story. But multifocality works fine, and your patients will be happy with it. So you have to advise them, yes, you hear these stories, yes, you will adapt to it in time, and no, you will be happy with the lenses. Sometimes some patients want absolute zero. For them, we have to offer them what we call the pill option. That means we do your cataract first, and 2 months later we will polish off the residue with the laser. That is easy to do because the residue is so small it just vanishes. And with that, the person can then be offered 100% vision.
So another question is, how early can you operate the second eye of a patient who's just undergone a cataract surgery? Can it be a day, a week, or is there a specified time period you would be for?
You know, there is a Society of Bilateral Cataract Surgery. A guy by the name of Ashinov is the president for it. There is no, provided you are willing to take adequate surgical precautions, that means totally different kits for two eyes, totally different sets of drugs, including the drips and the sets. There is no reason why you can't do it at the same sitting. It works equally well, I also do it. But the ideal time, if you take it from the point of view of safety, just to be sure that no problems will ensue, and then I think 48 hours is adequate. Because in 48 hours, if an infection is to ensue, it will ensue. The only thing you're worried about is infection. And nowadays that we have now started with this concept of putting antibiotics in the eye at the time of surgery itself, the infection rates have progressively dropped tremendously. And okay, the risks are still there. It's at present running in the rate of, I think, 1 in 15,000. But it's very acceptable. And you should consider bilateral cataract surgery, let us say in an old person, difficulty moving, difficulty to get around, a high-risk case, where there is no point in exposing her twice to the same problem where you can do it comfortably in one sitting.
And sir, we spoke about children. In a child with a congenital cataract, how early can we operate?
The correct answer to it is the day it is detected. Ideally speaking, it should be done as soon as possible. But there's a rider to everything as it is to this. Where lies the limits? It should be done within a period of 6 months. Why? Because after 6 months, amblyopia tends to supervene. Ideally speaking, it should be done a little earlier. 4 months is now taken as the guideline limit. It should be done within that period, provided your anesthetist can give you the guidelines that the child is stable and can be done. But if the child is stable, there are no problems, do it. The answer is simple, do it as soon as you can. Children heal very, very fast. And unlike adults where we need to put drops 4 times a day, in a child usually we don't need to put drops. We tell the mother that if the child does not let you put drops, don't touch the child. And in a child, when drops are to be put, remember the guidelines. Let the child lie down, put a drop in the corner of the eye and pat his stomach. Eye opens, drop goes in. Never try to open the lid because the eye's lid is very tight. Like a windscreen wiper, it just throws the drop out. So it has no relevance at all. So just put him on the flat down, put a drop in the corner and wait. You open the eye. He has to open sometime. The kid opens after some time to see kya ho raha hai. That is the time the drop goes.
So we've seen a lot of over-the-counter medication frequently by chemists, topical steroids given to patients. How often have you seen cataracts caused by such overuse or misuse of topical steroids?
Unfortunately, more often than we should have. All ophthalmic surgeons see steroid-induced cataracts by the use of drops. And the worst is not that. The worst is very often they are given by very correct ophthalmologists who have told them use it for 3 weeks. And the patient says, I felt good with it. Goes on using it until one fine day the vision drops and you see that there is a cataract. But on the other hand, life is not all that bad because the steroid cataracts are soft cataracts. They come out very quick. So I mean, you get a very good result after that. So it doesn't really matter. But yes, steroids should be given always with caution. Should never be given for more than 3 weeks at a time. And as far as possible, try and use the least effective steroid in comparison. Try not to use prednisolone acetate. Try to use any of the NSAs which you can use or use fluoromethazones rather than going that way.